I'm going to speak about essentially the mainstay of intervention for progressive myopia, and that is pharmacological control. So atropine has been around for more than 8 or 9 decades, but this new indication is essentially, it's like an old car with new tires. It's just doing something else for us now. The exact mechanism we still do not know, but we know that it doesn't work on accommodation, as Dr. Siddharth said. It is a non-specific muscarinic antagonist. So essentially, it blocks the muscarinic receptors. And there are some of the theories that tell us how it may be working. So it's possibly stimulating some neurochemical cascade on the M1, M4 receptors in the retina. That's one of the theories. Another theory is that it possibly inhibits the synthesis of glycosaminoglycans at the level of the sclera. And there's also a theory that it acts on the dopamine at the RP level, which cancels the retinal signals for eye growth. So these are some of the possible ways that atropine works. One of the other drugs that has also been studied is a specific muscarinic receptor called pyrinzipine. It was used as a 2% gel. The difference being it's a specific antagonist, so it had minimal effect on cycloplegia and dilation. But a lot of these patients, there are 2 big RCTs on pyrinzipine, and they found that it reduces the myopia progression by almost 50%. So this is not available still for clinical use, but this is a potential drug for the future. So these are the 3 main actual studies which is, taught us about atropine and tells us that this works. So I'm going to sort of simplify these studies by just talking about the main conclusions. So the ATOM-1 study, which was published in 2009, or more than a decade ago, tested 1% atropine. This was used in 400 kids, and they found that this worked very well. These children hardly progressed. So over 2 years, they progressed by 0.28. That is almost 77% reduction. This also showed in the axial length growth. But the downside of 1% was that you essentially had to prescribe some form of bifocal or progressive and even photo gray glasses. And the second big drawback was that as soon as we stopped this, there was a significant rebound myopia. Rebound myopia essentially means that as soon as you stopped it, the myopia just progressed much quicker than even the control group, which was not having any drops whatsoever. So they realized that probably 1% works well, but there are too many side effects. Let's look at some other concentrations. So then they did half the concentration, 0.5, 1/5 of that, and then they jumped straight to 1/10 of that, that is 0.01. It was a good study because it was a long-term study. It was a 5-year study. They used the control. They didn't have any placebo group. So they used the ATOM-1 ka placebo. So that was a drawback to it. But let's come straight to the results. They essentially said that 0.01 works very well. They realized that the stronger the concentration, better effect, but less the rebound. So they concluded that atropine 0.01 has minimal side effects, but it has a comparative efficacy. This is a very common sort of graph you may have seen, but I'll tell you what this is. This line going down, we have myopia on this axis. So this line going down saying that this patient is becoming myopic. This is the line that was the placebo, which kept on progressing over 2 years. This top line is the 1%, which in fact for some reason got better, but still progressed very minimally for 2 years. And these are the other concentrations we spoke about. This is 0.5, 0.1, and 0.01. So at 2 years, they found that these were quite similar, but as soon as we stopped the drop, this 1% dived right down and increased. That was the rebound effect of 1%. While the 0.01 almost had no rebound. So they said at the end of 3 years, if you had to give atropine and then stop atropine, you'd be better off giving 0.01 rather than giving 1% and then stopping, because you're in a better situation with 0. So that's how they concluded that 0.01 is pretty good. So that's where, the whole thing came up, that we are going to start using 0.01, and for the past at least now 7 or 8 years, it's become a mainstay of practice as that being the drop of choice, and that's available in our armamentarium. Then came the LAMP study. Okay, so the first phase of the LAMP study was published, in which they said, there was that 10 times difference between 0.1 and 0.01, which was tested by Atom. So they said, let's test the in-between percentages. So they said 0.05, 0.025, and then 0.01. And this one had a placebo group. So again, let's just look at the conclusion of the 1 year. At 1 year, they found 0.05 was the most effective. That was the strongest drop. 0.05 was the most effective. And this time they found that not only was it effective for spherical equivalent, but it also helped the axial length. It also showed on the axial length. So yes, this was a drop that was found to be most effective. They continued this study for the second year. This was published in 2020, and they found that the same result was seen, 0.05 being the most effective. So the efficacy of 0.05 in comparison to what we use 0.01 was double, where 0.05 progressed by 0.5 and this progressed by more than 1. So this was telling us there's one more concentration that may do the job for us, maybe slightly better. And now just 2 months ago, they published the 3-year data. This is a busy slide, so don't read the slide. I'm just going to just tell you the brief what the 3rd year study said. The 3rd year study wanted to check rebound effect. They have proved that 0.05, which is 5 times more than 0.01, is more effective. But does it have a rebound effect if we stop it? That's what they wanted to know. Just like how 1% had a great rebound effect. They found that yes, the stronger the drop, more the rebound effect. But they found that 0.05 had a clinically insignificant rebound effect, which meant that if you kept someone on 0.05 and kept someone on 0.01, then you stop them both. You check the rebound and check them at the end of rebound phase. 0.05 was still 0.75 less in power than 0.01. So are we looking at another concentration that we should be thinking of? So this is just a summary of all the studies. As you can see, going from 1% going down to 0.01%, the effect of myopia, the effect of preventing progression keeps on reducing. But the first 3, 1, 0.5 and 0.1, they all affect the pupil significantly. So they do need progressive lenses. These last 3, most of them don't need anything. So higher the dose, the better it is. But higher the dose, more the pupil dilatation and also more the rebound. So we have to just try and find that in-between dose. So is 0.05 that dose is the question. It's still not come into practice. We are still using 0.01. We're trying to increase the concentration. So some of us, if the patient doesn't respond to 0.01, we do go into 0.01 twice a day. There are no studies on that, so we don't know whether that's the right thing to do. And plus 0.05 is not available. So if we want to use it, we'll have to reconstitute it from the 1%. So I'm just going to briefly spend 2 slides to tell you what I do or what most of us do when a patient with myopia comes in. We definitely take parental history of myopia and retinal detachment, and in siblings as well. Check vision subjectively in an older child, but all of them should have a cycloplegic refraction. Perform axial lens definitely as a baseline before you start atropine, and once a year. And look at accommodation, look for accommodation lag. So the high risk factors where you want to treat with atropine more aggressively will come out of this. If you have a family history, if you have an early age myope, if you have accommodation problems, these patients, we know atropine needs to be used more aggressively. So how will we use atropine in these patients? First of all, don't start atropine in every myope that walks into your clinic on the first day. You want to know whether he's a rapid progressor. So I typically follow them up for about 8 months at least, if not 12 months, and calculate a rate of progression by doing cycloplegic refraction in at least one of those visits, if not both. If the progression is 0.75 or more in a year, if you can calculate that, then I would start the drop. Once at night, review them 4 monthly, and in a year you would know whether this is working or not. If he is 50% less than how he was progressing before, then it's working, which means he's a responder. If it's not, then he's a non-responder. Close to 20% of patients are not responders. So if they're non-responders, then consider adding a therapy or replacing the therapy. And Dr. Pooja is going to talk to us about that. We would stop the drop if you get an allergic response, if the patient is a non-responder. If you've had 2 years of treatment, you can look for a washout period and see whether they're still progressing, or if the child is, reaching the end of growth phase, which is about 15. So I'll stop there, and I'm going to